presentations from Congenital Heart Academy, including this presentation from Dr. Silverman. Thank you very much, Dr. Silverman, for sharing this presentation with all of us on our YouTube channel. So guys, you can check this presentation again later, and you can share with your team and whoever you think is going to benefit of this knowledge. And during this webinar, please talk to us, make all of your questions on the Q&A chat box. In the end of the session, we are going to try to answer all of the questions, and I'm sure this is going to be very interactive, and so everybody can participate. Just remind you that we are having this amazing series with Dr. Anderson. So we are having the next one on February on the 12th. So every Friday, 1 hour before the time of this webinar today. So 9 a.m. US time, 3 p.m. European time, and 5 p.m. Doha time. We have Dr. Anderson morphological sessions, and we are doing in a very interactive way with case presentations, and Dr. Diane Spicer presenting some live hearts. So it's been very, very nice. I hope all of you can join. We are very proud to announce that we are, as a partnership with Pittsburgh, we are going to broadcast live the Da Silva Center for Abstain Anomaly Symposium. So this is going to be a state-of-art webinar. It's going to be on the 20th of February. So please join all of you. This is going to be really, really amazing, discussing abstain anomaly, and including Dr. Anderson talking about morphology. This is going to be very nice. And to invite you to our second fetal cardiology meeting. It's going to be on the February the 25th. And so a lot of nice topics on fetal cardiology, even for a basic level. So if you are a pediatric cardiologist, or if you are a surgeon, a line health, a nurse, so if you want to know more about fetal cardiology, please join us. And now we are happy to have Dr. Silverman with us today talking about transposition, but he is going to be with us every second Monday of the month with a different topic, correlating the morphological features and the echocardiographic features of all the diseases. Thank you very much, everyone, to join us today. And please, Dr. Silverman.
Hello, Grace. I'm trying to share my screen.
Okay, go ahead.
Share, there we go.
Perfect.
Okay, so today we're going to, I think that's, everybody can see the screen. Good morning to you all. It's my pleasure to talk about transposition following the great works that have been presented here at the Congenital Heart Academy today. This is also done in conjunction with my various authors whose names appear here, and is also available on this other website, MD1 World, where we've published this as a textbook chapter by chapter, www.md1world.com. If you go there, you will see all the chapters, and they are purchased for a minimal fee of $8 to maintain the website. Now, my co-authors include Professor Bob Anderson, who's very well known to this group and is famous in his own rights as a great cardiac morphologist and embryologist. Dr. Diane Spicer, who is also associated with us, of Venture, and has provided a great number of the images for this particular presentation. And my colleague Philip Ursell, now retired from the University of California, who has provided us with the pathology images from my own university, University of California in San Francisco. So what is transposition? It's a combination of concordant atrioventricular and discordant ventricular arterial connections. As such, it can be found either as the usual or mirror image variants. Either subset, there are further variation in terms of the relationship of the intrapericardial trunks, the infundibular morphology, and the presence of associated malformations. Regarding the associated malformations, it is the presence of a ventricular septal defect or obstruction to the outflow tract of either ventricle that is of great significance. Now, in order to obtain complete echocardiographic imaging in transposition, as for any other condition, one has to use the sequential segmental analysis of all segments, noting the veno-atrial contract connections, atrial arrangement, atrioventricular connections, and ventricular topology. The fundamental feature in transposition is the discordant ventricular arterial connection. It is also important to note that the great vessel relationship in terms of space, coronary arterial origin and direction, and either their proximal course, while also available with other imaging modalities, can usually be well seen by echocardiography. An evaluation of the proximal great arteries and associated structures, such as coarctation and patency of the arterial duct, is essential. And demonstration of these features requires complete imaging from all transducer locations and positions, and we will use the views that are appropriate for the ultrasound and morphological pairings to display these comparisons. So let's begin first with the parasternal long axis view. And this specimen has been rotated to compare to the echocardiogram. In all of these examples, there will be a little icon here which shows the transducer location in the parasternal position and the plane of the imaging. I will not discuss this any further. So this is a parasternal long axis view. And also highlighted in this, we will also have how the echocardiogram is cut through the specimen to show the specimen on the right. And the labels will appear, as you see here. There goes the specimen. The labels will then disappear so that you can appreciate the specimen in full character. And then the labels will disappear off the specimen, and we will magnify this for those of you who are auditing this presentation on a smartphone, so that it zooms in, and this feature, of course, will be available throughout the presentation. Now, we can also look at the same anatomy from a subcostal or an apical view. And here is a heart of a 4-year-old who has transposition and has a ligamentum arteriosum between the aortic and pulmonary trunks. The left pulmonary artery and descending aorta are shown. The left ventricle has thinned out because this patient was unoperated and survived to 4 years of age. And then on the right, we see the still frame of the image, and the image will begin, and then there is black and white as well as color superimposed on this image, and then the images will be zoomed for those of you that are looking at the images on a smartphone, or also to provide you with the greater fidelity for the views. This is the classical view that I require for initial diagnosis of transposition. It is a subcostal oblique view, rotated in such a way that the anterior aorta and posterior pulmonary artery are both imaged. And here you can see the parallel outlet of these vessels. Here is the subcostal view. And you see the aorta and pulmonary trunks, right and left ventricles, and the anterior interventricular artery or left anterior descending, which separates the right from the left ventricle. And you can see the cuts are going from the ventricles straight into the great vessels, and the great vessels are in parallel position. There is no spiraling that occurs in transposition, as Professor Anderson has shown in his examples. And there you see the aorta and pulmonary trunk and the classical motion that is present here, and the fact that the liver is seen underneath the diaphragm because this is placed in the subcostal or subxiphoid position. Here are two other examples. Again, the echocardiographic cuts are shown on the specimen in this subcostal view. And then there's a more anterior and posterior position. Of course, the specimens have been cut through different areas to highlight different issues. So the right ventricle is shown to be continuous with the aorta, but the pulmonary artery is more posterior, and the left ventricle has only been cut through in a minimal position. When the posterior cut is included here, now we see the left ventricle continuing into the pulmonary artery with the ductus arteriosus shown here, which we call the arterial duct now. And the echocardiogram shows this as well in motion. And you see the right ventricle connected to the aorta, the left ventricle connected to the pulmonary trunk, with a little left atrium posterior to this. If we cut very anteriorly, we only get through the right ventricle. And here you see the opened right ventricle with the tricuspid valve, the papillary muscle of the conus, the septal papillary muscles, and the posterior papillary muscles here, subtending the three leaflets of the tricuspid valve. We can identify this as aorta because not only are the head and neck vessels shown, but we can also see the left coronary artery, and the echocardiographic plane is a similar one, but shows this large anterior papillary muscle, the aorta, and the origin of the coronary arteries to confirm this as aorta. Now, in case you thought that the aorta was always going to be anterior, here is a rare example of transposition with the aorta posterior to the pulmonary trunk. This is the so-called posterior transposition. Here's the right and left atrial appendages, the aorta and pulmonary trunk, and the cuts from the left ventricle going into the pulmonary trunk and the right ventricle going into the aorta. So the aorta is actually posterior. And here is a sweep which I've obtained from Dr. Shane Morris from Houston, Texas. And we will show you the 4 chambers here and scan in a cranial position. So here you see the 4 chambers, a small ventricular septal defect, the aorta arising from the right ventricle with the arch, and then the pulmonary artery from the left ventricle. Once again, the small ventricular septal defect, the aorta arising from the right ventricle posteriorly, the arch then, and then anteriorly from the left ventricle, the pulmonary trunk. So that's a very unusual thing, but I think confirms the notion of Professor Anderson that it's the relationship or the connections between the great ventricles that defines transposition. Now, when we look at the heart from above, there is a problem because our echocardiograms are looked at the heart from below. So right and left are reversed here. So the left side of the heart is here. The right side of the heart is here. So this is the right coronary artery arising from the aorta, which here apparently looks like it's left-sided, but from above, this is right. And there's the pulmonary trunk lying slightly posterior to it, and the origin of the left coronary artery showing the anterior interventricular and obtuse marginal branches and circumflex running around the left atrioventricular junction and showing the mitral and tricuspid valves. The same is identified on the aorta, but here only the anterior interventricular and left circumflex arteries are seen arising from the rightward positioned aorta in front of the pulmonary trunk. There's the right atrium, and here is the motion picture, and you can see the coronary arteries very clearly arising from the sinus here. Again, when we look from above, we can see as we go a little lower on the scan obtained by courtesy of Tony Lavacek, you see the pulmonary trunk appears to look like it's arising on the right side, but it's actually a left-sided structure, because here's right and here's left, and we're looking from above. And you can see here the aorta and the pulmonary trunk, the left ventricle, the right atrium appendage, and the right ventricle. I'll take those pictures off so that you can see them more clearly. Here's the echo cut shown over here, and here is the echo simulation of that cut with the aorta slightly to the right of the pulmonary trunk, but largely posterior, with the pulmonary trunk largely posterior, the atrial appendages, the superior caval vein, and the pulmonary arteries and descending aorta identified there. And I'll leave this with motion so that you can see these structures as they move. And then I will remove them for you so you can see the comparison in mirror image, one of the other images, as you see there. Now, looking at the position of the aorta and the pulmonary trunk in a patient where there is transposition, we see that as can occur that the pulmonary trunk can be on the right and the aorta on the left. Here is the cut here that we show over here. And you can see here this patient also has a single coronary artery coming from the aortic sinus and running over the arteries there. And here you can see that there is an aorta which is left-sided and a pulmonary trunk which is right-sided, with the left atrium and left atrial appendage clearly identified. So this would not be, if you were using Van Praag terminology, transposition SDD, but transposition SDL. Once again. And you can see the alignment between the coronary, between the commissural cusps of the aorta and the pulmonary artery, one next to the other, an important feature. Now, of course, the most important thing in transposition is to see, in a newborn, is to see the atrial septum and see where this is developed. And many problems relate to the closure of the atrial septum, which is the reason for urgent balloon atrial septostomy in the neonate. So we need to recognize this most importantly when we examine the neonate with transposition. And what I do here is I have a heart from my own collection at the University of California with Dr. Ursel that we are looking at in a subcostal coronal and a subcostal sagittal view to evaluate the atrial septum. And here you can see the limits of the oval fossa here with the septum primum obturating the entire foramen ovale. So if this was in life, this fetus would not have any communication between the left and the right atrium. And I've matched this, of course, with examples of the atrial septum in the subcostal, coronal, and sagittal cuts. And you can see here there's a teeny weeny atrial communication over here between the left and the right atriums. And when you turn this round, we can see superior and inferior vena cava, the tricuspid valve draining into the right atrium, the left atrium behind here, and a really minimal atrial shunt here. The consequences of the obstruction are, of course, quite significant. And so here, the next picture showing the same features in a subcostal coronal is from a neonate who presented with total obstruction at the oval fossa area. And you can see here septum primum has obturated entirely this atrial septum. And of course, this patient had markedly different saturations in the upper and the lower body because of the fact that the superior cava, superior body saturation represented the fact that there was very poor mixing at this area. And after balloon atrial septostomy, there was a widely patent area between the two atriums, and the saturations increased and became equal in the upper and lower extremity due to the mixing that occurs at atrial level here. Now, I thought I would include for you this technique, which I believe is the standard technique now for doing a balloon atrial septostomy. I have a radiological image showing the scan plane for the echo, and then you'll see here the catheter coming across into the atrium and crossing the atrial septum and lying in the right atrium, in the left atrium, I beg your pardon. And then I will show you the recording of a balloon atrial septostomy. And I'll just repeat this again and again so that you can see a good balloon tear with a short jerk and the catheter almost obturating the origin of the inferior vena cava. And you can see the actual force which ruptures septum primum over here. And here is the echocardiogram, which shows you the same features. And what I would like to point out to you that the echo, even though it's shown at 30 frames per second, will show you this distortion of what happens to the Rashkin catheter as it's brought across the atrial septum. You see here how this inverts and turns into a heart-shaped structure as it comes through the atrial septum. You can only see it in still frame, and there it is in the right, and there's the shunt that occurs after successful Rashkin. So I left that zoom up for you so that you can get another look at that by the two techniques. Done at the bedside, the patient doesn't have to be transported, and it can be done safely and effectively. My own personal preference is to use the umbilical vein, but many people prefer the femoral catheter route for these patients. And here's another example of one which shows a very interesting feature, because there is a mirroring of the septum as a catheter crosses there, and it appears that there are two catheters. This shot really reflects a mirror image of this, a reverberation of the image, and not a second catheter. Now, a good Rashkin should be done and evaluated. This was done by a fairly inexperienced person, and he was unhappy with it. So he did it again, and on the second catheter pull, he ruptures the balloon, and all of the contents of the contrast material are liberated into the heart. And you can see not only that there will be a left to right shunt, but also that there's mixing at atrial level, and this is oxygenated blood that is going from the atrium into the aorta here. So then after Rashkin, you see an adequate tear. I think we've shown you one of those, and in the interest of time, I will move on with this and show you some of the other problems where perhaps a Rashkin today should only be done when the saturations demand it, or when patients are going to have a long delay or transportation for surgery. But here's a patient with multiple fenestrations in the fossa ovalis, and you can see many holes in the septum from this example here. And here is an example showing multiple fenestrations over here. And in many patients in our institution where this is present and we know the patient will go to surgery fairly rapidly, we defer doing a balloon atrial septostomy if the saturations are adequate, because complications from balloon atrial septostomy have been described from our institution as well, the University of California. Now, then, once you've established the findings of the foramen and the patient's been managed, the next issue is to assess the magnitude of the shunt at the ductus level, because the ductus, when it's open, helps to fill the pulmonary arteries. The pulmonary arteries then return to the left atrium and drive oxygenated rich blood from the left atrium to the right atrium, and thence to the head and neck, and that's a very important thing. And also, it gives you a false sense of security if the ductus closes, the patient will get a much more cyanized. So in this situation, the use of prostaglandin E1 to maintain ductal patency is important. So here is a shot showing an opened ductus from Diane Spicer's connection. And there you see the pulmonary artery, the pulmonary trunk, continuing into the ductus. And here is the arch of the aorta. And here is a cut from the suprasternal notch showing you this very beautifully. And here you can see the left to right shunting that is occurring across the arterial duct here. Here is aorta with the arch, the ductus widely patent, the whole length of the ductus from the aortic end to the pulmonary end where it joins with the left pulmonary artery, and the left atrium, left ventricle, and right ventricle above there. Here is another example. This is from the Brompton collection of Professor Anderson. And you see the arterial duct strung out here, showing its continuation from the pulmonary trunk. And here on the echocardiogram in this oblique subcostal cut, you can see the pulmonary trunk and the aorta, the connections to the respective ventricles, and the presence of a small arterial ductus where the ductus shunt is hugging the anterior wall of the pulmonary artery and bouncing off the pulmonary valve before entering both the pulmonary arteries. And here is the descending aorta behind as well. Now, this is important. The position of the ductus is important. And I've shown you these two examples from our laboratory showing the presence of an arterial duct in the normal situation in transposition. And here is the aortic arch, and here is the ductal arch with the pulmonary trunk. And you see the direction of the pulmonary artery is here because in fetal life, the blood was coming from the respective ventricles and entering directly into these two arches. However, when there's obstruction to the pulmonary arch, then the pulmonary blood flow will come through the ductus into the aorta, and the arterial duct then becomes more vertical in its orientation. So here you see the difference between looking at a ductus which is horizontal and a duct which is vertical, as you see there. And here you can see the whole of the fetal thorax, the diaphragm with the liver below, the right ventricle continuous with the aorta, the pulmonary artery is coming off the aortic arch and entering the ductus. So when flow is in this direction, the ductus develops a vertical orientation. And you can see this, of course, in the early neonatal period as well. The next thing is to look at the ventricular septum, and we have to evaluate the ventricular septal communication in exactly the same way as we evaluate all other VSDs, and all kinds of ventricular septal defects are present in association with transposition. So here is the classical perimembranous communication. In this heart, the right ventricle here is communicating with the aorta. And I've shown the ventricular septal defect as a shaded area, which you can see through. And once you've identified the right atrium and the right ventricle with the septal leaflet of the tricuspid valve here, I will remove those labels. And you can see in this patient that this position is here. Here, the position is of a large perimembranous VSD, highlighted by the green shadow. And you can see that the great vessels are, I beg your pardon, that the atrioventricular valves are on exactly the same level. As well here, you can see the subpulmonary position of this perimembranous interventricular communication. Now, sometimes the tricuspid valve, which normally tends to close, the septal leaflet of the tricuspid valve tends to close the VSD. Here we see the whole tricuspid valve with these tricuspid tissue tags, which are herniating into the left ventricular outflow tract and just below the pulmonary trunk. And here is such an echo example of that. Okay, and you can see here that this looks like a left ventricular to right atrial shunt, but indeed the base of the tricuspid valve is over here. And this is just this section of the tricuspid valve as we look at it from the left ventricular aspect, herniating underneath the pulmonary trunk. And I'll put that in motion so that you can see it. And this is the subcostal coronal cut. And there we see the pictures there. And now we can see them on the right side in a parasternal long axis view with aorta and pulmonary arteries exiting the heart in parallel fashion. There's the pulmonary valve opening, and here is this tricuspid valve herniating into the left ventricular outflow tract because the pressure in the right ventricle exceeds the pressure in the left ventricle because of the vascular resistance changes between the aorta and the pulmonary trunk. So now we'll just look at that and zoom up the echocardiogram on this side so that you can make that comparison. And now I will turn the echo specimen around and zoom up this so that we can see that when we look at it in parasternal long axis, we can see this little bit of herniated tissue. And so here you are looking at another example here. Oh, I think I removed that. So we're now looking at muscular ventricular septal defects, which are frequently multiple, as you can see over here. And you can see the ventricular septal defects there between the two there. And all of these multiple muscular ventricular septal defects. Now here's an isolated small VSDs, not related to this large VSD here, and associated with a cleft in the mitral valve frequently seen in transposition. But what I'm trying to highlight over here is the position of multiple muscular ventricular septal defects. And here's a large one, and here's a small one over here. This maybe not need to be surgically attacked because of the high incidence of closure of these defects. So you see small apical muscular ventricular septal defect here, which is what I'm trying to identify for you here, and large large ventricular septal defects. Here is the aorta, the outlet septum, so it's overriding the ventricular septal defect. And here we see the membranous defect, and here we see on the echo, which I've rotated round so that it compares. This is a parasternal long axis view rotated on its side to show the ventricular septal defect with the pulmonary and aortic trunks, and the outlet septum over here slightly anteriorly deviated and bringing the pulmonary artery to override both great vessels. Here's another muscular outlet ventricular septal defect, and this one I've shown you to show you that it almost looks like it's perimembranous, but there's muscular extension over here, and this can be seen from the left side very clearly, where this VSD is surrounded entirely by muscle. And here you can see on the echo an additional feature that there is slight posterior malalignment of the outlet septum, and you can see the ventricular septal defect, the septum marginal trabeculation on the ventricular septum, as well as the coronary arteries arising off the aorta. Anterior right and posterior left coronary artery, and posterior deviation of the outlet septum. Now, muscular ventricular septal defects can be so small that they often difficult to identify without the use of Doppler color flow imaging. And so here is a small perimembranous, muscular ventricular septal defect anteriorly in the apex. And you can see that there's actually some endothelial proliferation occurring, beginning to attempt to wall this defect off as we look at the right ventricle with the septum marginal trabeculation, the right ventricle the muscle of Lancisi and the septal tricuspid valve with a coarse apical trabeculation. And in this here, you will see here is the ventricular septal defect that we identified. But here also is an additional ventricular septal defect. So one of the important adages is that when you find a muscular ventricular septal defect, always look for a second. If you find a second, always look for a third. So multiple muscular VSDs are the rule, and they may close. Here is the spontaneously. Here is the next example of a posterior malalignment of the ventricular septum. When the outlet septum is malaligned, it narrows the left ventricular outflow tract and increases the size of the ventricular septal defect. This heart has been opened in clamshell fashion, and this here is the septal surface, and here is the parietal wall with the mitral valve attached to it. And you can see the outlet septum has deviated posteriorly across this defect. So here is this posterior alignment shown from a subcostal coronal cut. The septum is deviated, narrowing the entrance into the pulmonary trunk. And here in parasternal long axis, you get to see this very clearly. This is one of the rare examples where the actual illumination of the morphology is better when you look at it on the echo on 2 dimensions than looking at the actual image here, which is quite hard to appreciate. Now, the coronary arteries are our next thing. And I think it's important for us to be able to tell the surgeons about the coronary arteries well. And if they're seen and well seen, the question of whether further evaluation is necessary, it depends on the confidence of the surgeon in your ability to define these pictures, as well as your own comfort. But there are many other techniques, such as CT and also a catheterization. And I think that that really is depending upon your level of comfort as a cardiologist or a trainee with this condition, and the surgeon's feeling about how much he can trust you. So here we look at once again at this heart, where the left side is here and the right side is here, and here is the plane, and we're looking at the coronaries. This one enters this coronary artery, this sinus over here. This coronary entry enters this sinus here. This is the left coronary artery. You can see beautiful alignment between the commissures of the pulmonary and aortic trunks. And on echocardiogram, we often cannot see these together. This is a high frequency 15 megahertz linear array probe, which I've used in the past to look at the coronary arteries. And here you see the left anterior descending coronary artery in this neonate with the anterior interventricular or LAD and the circumflex running around, the position of the great vessels, the alignment between the two, and the left atrium posteriorly. And then with slight rotation round, we can look at the origin of the right coronary artery, which we see entering over here in an oblique fashion into that cusp in front of the pulmonary trunk, as they usually do. Now, here I've used another one of Dr. Lavacek pictures and show you see the head is up this way, and this is the right side. So this is the tricuspid orifice, and this is the pulmonary trunk here. And here comes the left coronary artery, and it's coming from sinus number 1, because the object is, if you stand in the non-coronary cusp or the non-adjacent cusp, and you look, sinus 1 is to your right hand. So if you're standing here, your right hand will be this way. Okay, so this is sinus number 1. And sinus number 2 will show you the origin of the right coronary. The problem with echo is this is looked from above and this is looked from below. So it is completely the different situation. Sinus 1 is still on this side, and sinus 2 is on the other side here. So there are the two sinuses. So you can see that the sinuses then will be mirror image. So when you hear people talking about this, or when you do this, you have to either know which sinus is which, or you have to put yourself standing upside down in the outflow tract to recognize which hand is going to sinus 1 and sinus 2. But anyway, whatever it is, sinus 1 or sinus 2, we can identify the coronary arteries here very beautifully, entering the adjacent facing sinuses of the aorta. And I think the origins of the courses of the coronary arteries can be well seen. And we'll obviously listen to what Dr. Agati would say about what his feelings are in the editorial in questions and answers on this very topic. Now, here again is another morphological view. So this is the left coronary artery and the right coronary artery here. Another picture from Dr. Vlavacek, where he's compared this to the echocardiogram. So he's got the right coronary artery and the left coronary artery, and sinuses 1 and 2 seen as an echocardiographer would look at this. And here is sinus number 2 and sinus number 1 as we see it here. I think this is quite confusing, and one of the reasons why I don't like to use it, I say that from the left-facing sinus and the right-facing sinus, and then I get myself out of trouble. Here's another look at the coronary artery dissected by Dr. Spicer, showing the anterior coronary running in the groove, together with the sinus node artery and a conus branch coming off the right sinus over here. And here on the echocardiogram, you can see this in still frame as well as in motion. And I'm going to stop that for a moment there and get rid of the labels. And then I'll allow you to look at this. And we can do this, of course, with all of the examples. I hope you can do it on YouTube, where you can see the coronary artery draining into the sinus here. Here's the coronary artery running in the AV groove between the atrium and the ventricle and entering the aorta here, and the sinus of Valsalva clearly identified. So you can see that the interesting issue is that as the heart is twisting and rotating, we only get to see this for a short period of the cardiac cycle. And for those looking at the iPhone, perhaps I won't repeat this, but you can see very nicely how this coronary artery is only seen for a short period as the heart is ascending and descending and twisting. And then, of course, we can see some of the coronary variations. Here, coronary variations, you see the left circumflex and the right coronary artery joining into the aorta. Here is an example from Dr. Vlavacek on this particular topic. This is the commonest anomaly of coronary arteries. And here you can see very beautifully the origin of the arteries coming into the aorta. And of course, once again, we will have to look there and see, it looks like these two arteries are joining and coming through a common orifice into the coronary vessels. So let's just let this play here for you in the real-time frame. And here you can see very beautifully how to do this. Rotate around in a sort of a plane where you can see it's a more horizontal plane, and you can see the coronary arteries in different periods of time, but in one cardiac cycle, you can see them coming together into the sinus of Valsalva. And here's an example from Dr. Francesca Raimondi from Paris, who she gave me this beautiful picture of the circumflex and the right coronary draining into the aorta. And here is the echocardiographic picture of the same. You can see the peripheral pulmonary arteries, the aorta and the pulmonary trunk. And when you put this in play, you get a much better appreciation of the vessels here. Here goes the circumflex down here. Here comes the coronary here. And in this particular instance, it looks like there's double orifices in the sinus of Valsalva before it enters the heart. So that can be easily done. Now, the next commonest anomaly is a common orifice from the sinus over here. And this is a cartoon drawn by Dr. Terry Tacey from a paper we wrote together on identifying coronary arteries in transposition. And here you can see the left main coronary artery, and it bifurcates and runs forward as the anterior interventricular and heads around the orifice of the annulus of the valve as the circumflex coronary artery. And you will also notice, in addition, unlike the drawing here, where the commissures are aligned, that the commissures are malaligned in this particular example, and we'll get to that in a moment. So there you go. There you see how it's only possible to glimpse at this during the coronary cycle, the cardiac cycle. But I think it's quite clear that this is a common coronary artery with both the left anterior descending and the circumflex arising from this vessel. Now, a single coronary artery may arise anteriorly, as it does here in this example. And here you can see an echocardiogram, which I've frozen in still frame so that you can recognize the right coronary artery and the left coronary artery arising from a common orifice. The left coronary and the right coronary arising from a common orifice. Sorry, there was a bit of a tachycardia here. Not easy to do, but really I think that can be done. And here's that same patient I showed you a little earlier with a single orifice from the right side. And here you can see the origin of the right coronary artery. You'll see the branches in motion now. Here's the left coronary artery running here in front of the aorta. Here's the conus branch. You see the left coronary artery and conus branches and the right coronary artery running in the AV groove. And let's just take the labels off that there. Here you see the orifice very beautifully with the labels off, the large right coronary artery subtending the left coronary artery as it runs anteriorly and gives off the conus branch. This is the big problem, an intramural coronary. Now, the surgeons can obviously recognize this, but it's very nice for the surgeon to go to sleep knowing that the next morning he's going to have to do, or she will have to deal with this. And so here you can see an intramural course here, this coronary artery, the left, and this is courtesy of Dr. Andrew Cook, my friend from London. And here you see this vessel crossing the commissure. That's one of the highlights. The coronary crosses the commissure. Should be going in here, but goes in here. And so here you can see this on a 2D echo. I'll take these labels off. You see the sinuses and the labels tend to obfuscate this issue. So here we see there's the left coronary rising from a separate orifice off this sinus over here. Okay. There's the pulmonary artery behind. The left coronary artery is more commonly intramural than the right. So the right's running in the appropriate coronary sinus. This one should be running over here, but it runs in here. And this, of course, creates a series of problems for the surgeon in repairing them. And when the artery has an intramural course, it often runs between the pulmonary artery and the pulmonary trunk and the aorta distally. And so here we can see that feature. I think it's very important to be able to see this. It's actually from the same patient. Excuse me. And so you'll see, I'll take this off so that you can see the intramural coronary artery running out here and running between. So there's not only an intramural, but an interarterial course of this coronary artery. The coronary artery may arise from a solitary right-sided structure. So here, a left-sided structure. So here, there's the opposite to what we've shown you before, where the coronary artery came on this side. And these are surgical pictures taken by me at the University of California and at Stanford, where I worked. And you see there's a high origin of this coronary over here. And here you can see an echocardiogram showing the sinotubular origin of the solitary left coronary artery. It's not the best picture, but I think it shows very nicely. Here's the sinotubular origin of this, and this is another pointer to the possibility that there is an intramural cause. Now, here is a beautiful example from Dr. Spicer's book from above, showing a commissural malalignment between the aortic commissure and the pulmonary commissure. And you can see that in the normal heart, they are aligned here. I put this in here with the usual alignment. And then here's an example where they are malaligned. Okay, I'll take the labels off, and I have these little cartoons to show you the difference here between the two. So this is the pathology. So that looks like the vessels are left-sided, but they're not. It's we're looking from above, and this looking from below. And here's the coronary artery coming in here and here. These are not associated in this particular example with an intramural course. You can see very clearly that this is not intramural. And when we zoom in on this, you can see that as well. Now, sometimes the right ventricle is small, and here's an example of a small right ventricle, frequently associated with coarctation of the aorta. And this was done in the operating room with transesophageal echo from a subxiphoid or intragastric position, showing a sort of subcostal sagittal position of the aortopulmonary trunks, the difference, and the small size of the right ventricle in this patient. So small right ventricle is a problem. Here's the subpulmonary stenosis. We've seen this picture before. I've got an echo picture. We've seen similar issues, but you can see how the left ventricular outflow tract is narrowed, and the surgeon actually, if he's going to do a switch, has to remove this muscle, the outlet muscle, conus muscle, from below the pulmonary trunk. Parasternal long axis and subcostal coronal cut showing the narrowed orifice at the entrance, whereas the pulmonary valve is somewhat different to distal to this particular pattern. Here's another example of subpulmonary stenosis with a heaping up of endothelial and fibrous tissue within the left ventricular outflow tract, and here an echocardiographic representation of the same. Here's the so-called cleft in the mitral valve. This is really attached either to the crest of the septum or may even straddle the ventricular septum and go into the other side. So here you can see the cords attached to the crest of the septum on both of these examples, showing that this is the mitral valve does not attach to the septum. When it does, it usually means either you're dealing with some form of AV septal defect or you've got a cleft in the mitral valve. And I'll show you another example of this now. Oh, no, I won't. Sorry. And here is another rare example. Conotruncal defects may occur together. So here's an example of transposition with an aortopulmonary window. This is just all you can see of the pulmonary trunk, but here shows the window very beautifully. Again, an intraoperative example that I took of one of my patients who had this. And here is the representation of this. Here you can see in this subcostal sagittal cut, you can see the window between the aorta arising from the right ventricle and the pulmonary trunk arising from the left ventricle. So this patient was repaired, and of course, this is easily recognizable on the magnitude of the size of the shunt of the window here in this patient, and was seen if you turn the probe round exactly at 90 degrees, you'll get this picture with the aorta going to the descending aorta, the pulmonary trunk left and right atriums, and the pulmonary trunk behind, and the window also seen there. And here is an example of so-called crisscross or twisted atrioventricular relations. I'm going to take the echoes to show you the top one here and the bottom one here. And this is a difficult concept to appreciate, but here's the right atrium draining concordantly into the right ventricle through the tricuspid valve. The left atrium, not seen, drains concordantly to the left ventricle, which is seen below. So what's happened is that the heart has actually twisted. I don't know whether you can see my hand over here. I can't see it, but when you get this twisted relationship, it's after development and a twist occurs. And my thumb, as you can see, changes its position. As you will see here, the aorta then rotates leftward, and there's frequently an SDL or leftward positioned aorta with discordant atrioventricular connections. So let's just let you look at this beautiful example of a crisscross from Diane Spicer's collection. And now we see here the echocardiograms, and this is a subcostal coronal cut. I got this when I was in Malaysia as a visiting professor, and you can see, let me just get the labels off for you. Okay, you can see as we stop this, we see the pulmonary artery connected to the inferior left ventricle. We see the right ventricle connected to the aorta, and the aorta is levo-opposed. Okay, now we're going to have to look at the atrioventricular connections. And I'll let this play here. And you can see that the tricuspid valve drains into this ventricle, and the mitral valve from the left atrium drains into this ventricle. And if you're having problems seeing it, let's look at this in the subcostal sagittal cut, which is a cut at 90 degrees to this one. And here you can see the left atrium here draining to the morphologically left ventricle, to the pulmonary trunk. And as we proceed further and scan, you can see the right atrium draining through the tricuspid valve into the right ventricle, and that draining to the aorta over here. So I'll let that play for you in the 3 dimensions so that you can appreciate the little tricuspid valve draining into the right ventricle up here, and the mitral valve draining into the left ventricle here, and the transposition. But in this case and in this case, the aorta was levo-opposed because of the twist that occurred after development. Now we're getting to the end of this. I'm going to stop in a moment here, and you'll see AV canals associated with transposition, AV septal defect. And here you can see the superior and inferior bridging leaflet. Invariably, this is a type C of Rastelli canal. Here is the aorta draining above the ventricle. This is an inlet defect. There is the pulmonary trunk coming off the left ventricle, but not shown. And lastly, juxtaposition of the atrial appendages. There's an example of juxtaposition. Here's the echocardiographic plane in subcostal coronal trunk, and you see the right atrial appendage has swiveled from the right atrium around the back of the great vessels, and it presented itself above the left atrial appendage. So here you're going to have to watch this. It's very difficult to see. There's the small left atrial appendage, and here's the right atrial appendage running behind the pulmonary trunk and situated above the left atrium. Okay, so you have to watch this in a number of planes. So now we go from back to front. There's the left atrial appendage. Okay, here's the right atrial appendage. Oh, we've missed it. So we'll see left atrial appendage. There's the weeny left atrial appendage. Okay, and now we look a little higher and we start to see the atrial septum twisting as well. Okay, do you see the atrial septum twists as well? And here is the right atrial appendage, and here comes into plane the aorta and pulmonary trunk. So as you come forward, you see the big pulmonary artery coming from the left ventricle. Now you can't see the appendages anymore because we're too anterior, and then we come even further anterior and we see the aorta with the coronary arteries. So we know there's transposition, but we see that the atrial septum is twisted around. There's the big right atrial appendage on the left side, and if we go backwards, we'll see the small left atrial appendage here on the left side. Here we go. There's the little left atrial appendage. So juxtaposition of the atrial appendages. Now I have one or two pictures more. I think I will go until what Grace tells me it's enough. Here's a mustard procedure in a heart, and you see the inferior and superior vena cava are connected to the left atrium, and the pulmonary veins drain over the baffle into the right atrium. There we go. Okay. And here you see the pulmonary venous atrium and a piece of the systemic venous atrium, as I call it. And you see color flow shows clearly open areas. So this is going to be what is seen largely by people in congenital heart disease. What we see more is the arterial switch here with the pulmonary trunk arising off the corrected procedure in 3 dimensions, and the pulmonary arteries in front of the aorta. Here, the pulmonary arteries on echo in front of the aorta. Usually, the pulmonary artery is behind the aorta, the branch pulmonary arteries. And here is what I call the pantaloon or trouser legs of the pulmonary arteries as they straddle across the aorta. And another example that you can see subcostally, where we look particularly at the branches to make sure that they are not stenotic. And this is an ongoing investigation. And here's an example of the arterial switch post-operatively, showing the sutures running between the aorta and pulmonary artery with the origin of the reimplanted coronary arteries identified with suture running around the coronary artery. And the late development of aortic root, neo-aortic root dilatation here that occurs together with pulmonary insufficiency, which is a complication that usually occurs when there is a ventricular septal defect and massively enlarged pulmonary artery. So you see here right atrium, mitral valve, you see the dilated neo-aortic root, you still see the suture line, but you see a fairly substantial amount of neo-aortic insufficiency. And with that, I will say thank you to you and tell you that the next time we meet, we will be discussing this concept over here, the concept of congenitally corrected transposition in March. And you can also find this on the MD1 World website if you'd like to look at it and pre-digest it before we make this presentation. Thank you very much, Grace and Sasha.
It was amazing. Norma, it was very, very good. Thank you very much for that. We have very interesting questions. And I have one question from myself to start with. So when we have tricuspid atresia or mitral atresia, so it's easy to understand when the ASD is restrictive. You can see the gradient and everything because the flow has nowhere to go. But when you have a transposition, that you don't have any obstruction, the outflow tracts of both ventricles are normal. So how do you evaluate if this ASD is restrictive? Because the gradient probably is not that important, right? You go more
well, the gradient will develop when it's restrictive. Okay, it doesn't develop when it's not restrictive. Grace, this is a long talk. I have written a paper about this in the Journal of the American Society of Echo, JACE, with my colleague Raj Pan, where we evaluated this in utero. It begins in utero.
Okay. Very nice.
Now, what happens, we know that the oxygen saturations in transposition are different. So the brain receives a lower saturation and the pulmonary artery receives a higher saturation because they're coming from the wrong vessels. Nature has gone wrong. Okay. And when there's increased oxygen to the pulmonary circulation in the third trimester of a fetal life, and it's important to know this, the third trimester, then the oxygen sensors in the pulmonary circulation, which have developed only in the third trimester, start to provide vasodilatation. That increases pulmonary blood flow and diminishes ductus flow. So the ductus gets small and the pulmonary arteries get large. Now the lung only extracts a minimal amount of oxygen so that there's a higher oxygen coming back, and that increases venous dilatation and increases pulmonary venous flow. When that pulmonary venous flow occurs, the septum moves closed towards the fossa valus, and eventually may even fuse. And these are the patients that are the most critical when you see them in the neonatal period. These are the patients, as I showed you in my presentation, that have an oxygen saturation to the head of 60%. And of course, the ductus right to left shunt is 80%. So the toe has got an 80% saturation and the arm has got a 60% saturation. And these patients are screaming out for a balloon atrial septostomy. Those are the patients in whom it is critically important that they get an urgent procedure. And so what happens during gestation is that when the septum is held against the foramen, it starts to close. Okay, so you can understand the origin of this. Dr. Abraham Rudolph, my mentor, has written also a beautiful paper on this, which can be seen in pediatric research on the theoretical basis, and even argued about if you could close the ductus venosus in utero, you could reverse this oxygen saturation increase to the left side. But of course, that's a radical procedure, and we have other better procedures for that. I hope that's a good answer for you.
Very, very comprehensive answer. Thank you very much. I have one question from Miguel, and this is a question that Sasha will help to answer as well. So he's asking about when the coronary arteries are not well defined by echo, what should we do? So if we should move forward to do angio-CT. So this is my question.
I think, either cath or CT, I think is the appropriate answer. That's really a choice. A lot of surgeons, I'll let Sasha talk, but to my mind, a lot of surgeons are fearless anymore. They can fix anything.
That's exactly my question.
And
do we need to advance for further imaging, or Sasha, are you happy with only the echocardiography? Say, hey, I'm not quite sure about the coronary arteries.
No, I think that we learn from the best, like Norman, that you have to build the team together. So I think that the echo is important. Then you invite the cardiologist in the theater if he saw something different, and of course try to improve the level of knowledge in this. I don't think that at the moment CT scan, because the heart rate still remain a big point for the good evaluation of the coronary heart. This comes from our experience, but at the same time, I think that echo is a real gold standard for mostly 90%, more than 90% of the diagnosis.
But my question,
and of course, there's always cardiac catheterization, and a lot of people, I don't think it's necessary in the majority of patients, but obviously if there is an issue, then I think, you can consider cardiac catheterization. Let me say one important thing about the echo that I need to tell the listeners here, and that is that when I look for coronary anomalies, we don't look at it when we're worried about the Rashkin procedure, okay? When we do the Rashkin procedure, we want to make sure that the patient has adequate oxygenation. That's the first and foremost goal, and why I put the atrial septum down first in this presentation. So what we do is we'll stabilize the patient, do the Rashkin procedure, and stabilize the patient. Let the patient recover from the Rashkin procedure, and the next day, before the surgery, go back and spend the hour looking at the coronary arteries to make sure that they're okay. Okay, so we do a second procedure, and even take a second physician or sonographer with you, and have a look and develop a consensus for those. My paper says this. Make a consensus for this, because interpretation is fundamental over here. So that's what we do. And then, of course, we also will talk to the surgeon. And if we tell him we're uncomfortable, you know, I've been in the operating room with the surgeon, which is I can recommend to all the viewers, is when you go in and you watch the surgeon take the little brain probe with a little nipple on the end and go from the inside of the vessel and see where it's going on. You see, when we become a team, Sasha, we really come into the operating room with you and see. I can see you're laughing at this, but we know what the surgeon's doing. They don't trust anybody. They, in the end, they handle it, and they're going to look and see where these vessels are running, whether they have an intramural course. I think what we do for the surgeons is just give them a peace of mind now, because when we tell them that the coronary arteries are normal and they go to sleep, they feel much better the next morning when they're operating. When they know that there's going to be a coronary anomaly, they don't sleep so well, okay, because it's a different system, and it's always a risk when the coronaries aren't absolutely wonderful. That's what I got to say, Shasha.
I think that it depends by single experience. For example, in Paris, they do 600, 200, it means TGA per year. Yeah. So there, the cardiologist can look to the coronary without closing the eyes. Don't look too much, because is a big school. So my message is, I think that to spend time, you have to learn from the big. You have to try to, because mostly of the time, this is not a direct sign. Sometimes we learn from indirect sign. The course of the circumflex on the echo, if come from the right, rather than to look directly to the ostium. So I think that there is a lot of tips and tricks in order to improve. But if the question is, I would like to do CT scan or angio before TGA, I don't think I will never do. Mm-hmm. I prefer, I will maintain the suspicion. Mm-hmm. But of course, if there is if there is an intramural course, I'm sure you will treat. Also, if you know before, of course, you discuss with the family in the right way, but at the same time, you must treat intraoperatively. So this is what I think.
Okay, because on the early stages, the coronary course would be a contraindication for arterial switch. Nowadays, it's just the prognosis that changes, right? So we don't contraindicate.
Arterial switch supporter. Yeah, no other surgery for.
Agreed. So we have another very broad question. This is very interesting. There was a question about how do we evaluate if the LV is ready for the arterial switch when the patient comes in a late presentation. Yeah. So LV mass, the septum. So how do you do this evaluation?
Well, we at Stanford and UCSF have used MRI under this circumstance to look at left ventricular mass. The large part of where we've done this has been, we don't see 4-week transpositions, very unusual. So I don't have a great deal of experience, but when we do a left ventricular preparation for a switch, we look at this by MRI largely. And what I think is very useful is to look at the left ventricular wall by M-mode echocardiography, because you get to see the thickness of the ventricle. And I think what we've discovered when you band the pulmonary artery in these patients, that the mass of the left ventricle increases. You know, I think it's only a single sole look at the left ventricle, but I think that it's a very useful way. We always calculate left ventricular mass based on a two-dimensional echo with the biplane analysis. And of course, three-dimensional echo allows this a lot better. My experience from the arterial switches is that the late switch for congenitally corrected transposition, or those, is that when the left ventricle hypertrophies, the results are usually good for the switch. So I think that I would really rather refer this question, a 4-week-older. I think you know, you'd have to see whether you can do that. And I don't have any experience, so maybe Sasha, you can bail me out and help me on this particular issue.
No, I think that, as you said, there is not a lot of paper. There is a big experience during, you know, for patients from foreign people, child coming from
refugees and
yeah. There is a lot of experience about this, and I think that it again is case by case, banana shape on the echo, all the things, as you say, the M-mode evaluation. But I'm sure that also if the LV suffer a lot postoperatively, if you treat in a place where you have ECMO or you have assist device,
I think you have to have ECMO, yeah.
Yes,
but I think you know, I mean, under a late transposition like that, my instincts as a cardiologist would be to catheterize those patients and see what happens. And in fact, what I would do if I was catheterizing a patient like that, I would blow up a balloon in the pulmonary artery for a period of time and see what happened to the left ventricle, with how it responded. If it responded favorably, then I would say I would be happier with the switch. If it responded less well, then I think you've got other non-invasive interventional techniques that you can consider in this situation. No. And you may even have to then band the pulmonary artery. But I think that that's, and banding the pulmonary artery, I mean, I'm going to discuss this next month in the congenitally corrected transposition. You know, I mean, we've worked with the surgeon and we do hemodynamics in the cath lab, in the operating room. Yeah. The surgeon will put a catheter in the LV and in the pulmonary artery and place the band. And then he will ask me to do the transesophageal echo. And while he tightens the band, we see what happens. And he tightens it to a certain level, okay? And then he asked me what do I think of the left ventricle. And my response to him to look at the left ventricle is to say, the left ventricle's handling this, okay? What happens if he bands too tight, the ventricle dilates and starts to function poorly? I say, Frank, it's too tight. You have to lower it down. And he'll then lower the band, just like you would do normally when you in the operating room, look for the band, and you know, then you lower the band and you leave the patient with that to get off and accommodate to growing the left ventricle again. That, I would say that's what I would do if I was ever confronted with this situation.
No, we have a very big chat with the delegates of Congenital Heart Academy. One day we discussed a case like this, and my proposal was a rapid LB training, retraining, as you were. I am very happy that, because of course it's something that doesn't come easily in the papers, and it comes mostly in the practice. And again, the opportunity of the academy is to share and discuss things that probably will never reach literature or will never reach a journal. But I think that this is the best way to share.
But to answer Dr. Arapa's question, I mean, I'm asking you, do you do 4-week? I mean, there are papers in the literature where people do arterial switches straight at 4 weeks. I mean, but when you get to 2 months and 3 months, and if the left ventricle is is thinned out already, and it does this very rapidly. We know this from the natural history of transposition when we were just doing Rashkin procedures and waiting 6 weeks or 3 months to do a Senning or a mustard operation. You know that the ventricles thin out and assume a physiological relationship that is much more typical of the afterload that they're seeing. So the right ventricle tends to hypertrophy and the left ventricle actually atrophies. The one specimen that I showed you from my own laboratory had a 1 millimeter thick left ventricle. There was nothing wrong with it, but it had accommodated and even atrophied to accommodate to the pulmonary blood flow at low vascular resistances. So, you know, I think all of these things would be what I would consider, Dr. Arapa, but I can't give you anything more than that.
Okay, very good discussion. I think we can have one last question.
No,
and then
I have one clinical case now, our CT scan. So I would like to share with you all.
Okay.
Great.
Is it possible?
Sure.
Of course.
This is the basic CT scan. Is a 9-month child with that was coming from South America here for a surgical treatment. They did the evaluation. They say that is detrasposition in levocardia. But then we did the angio today, the CT scan now, and this is the and this is what they found really. So it means the is a double district for superior, the right and the left superior vena cava coming into the right atrium. As you see, there is a huge pulmonary artery with a rising from an anterior left ventricle, and the aorta is in this position, is the right side, and is coming posterior from a right ventricle. So I want to know your idea. Did you ever see?
Talking to me, Sasha?
Yes.
Well, to me, this smacks of isomerism. Okay, you've got the bilateral cavers, you've got the posterior transposition. There's obviously in all of these cases with posterior transposition, there is a VSD. I would like to see more information than you show me on the CT.
Yeah, sorry, but this is the only one we take. This is the only one we take from angio. I will send you the echo, but there is 2 VSD. One is a muscular, one is a perimembranous.
Yes, and the vessels are aligned appropriately to the ventricles.
Yes.
And the VSD, the one is almost perimembranous underneath the great vessel root. That's a typical appearance for this issue. You know, I mean, there's no world experts on this condition because it's not that common.
Yes.
But you know, I would chase isomerism on this patient because with the bilateral SVCs, is there any evidence of isomerism in this patient?
Is a juxtaposition of the auricular rather than.
Well, there you go. I mean, Bob Anderson has got the most beautiful description of juxtaposition. He says juxtaposition is the harbinger of serious congenital heart disease. And although we loved in the days before Rashkin to have juxtaposition so we could do a intraatrial anastomosis, it's usually associated with severe problems, the juxtaposition. You know, with all of this, this everything needs to be worked out on this patient. I mean, this patient for sure has to have a full cardiac catheterization. And I mean, I think you need to think about also whether CT or MRI is the most appropriate way to get some more information. And when I say full echo, I would also include a 3-dimensional study on this patient as
I will ask Elliot to do this and send to you.
Okay. All right, but thank you for sharing that to show us a patient with posterior transposition, and I'd love to get some more pictures because I only have very few of them.
Yes.
I had to ask our Dr. Shane Morris for a patient that she presented at the American Heart Association meetings with this condition. So it is a rare condition. There you go.
Very good. I think we have time for one quick question, and then we close up. There's one question regarding how would we differentiate when there's a transposition with VSD if this patient is suitable for total repair or univentricular pathway?
Well, that's a complicated question. I think that, look, the VSD is not a problem. It's a question of whether there's malalignment that he's really asking, because basically if the vessels are normally situated, there's no problem with doing the switch. Okay, and you can even use hybrid procedures to close muscular ventricular septal defects. If he's talking about the posterior malalignment, I don't think there's a problem because the outlet septum can be actually excised. Remember, when the surgeon does an arterial switch, he actually amputates the vessels. So all you have to do is lift the valve and you see the subaortic obstruction. So I think that can be done surgically. You know, that's not an issue. So from that point of view, that's the case. If, of course, there is a long tubular narrowing of the outflow tract, that becomes a problem for a two-ventricle repair. And you'd have to think about how severe that is and when you follow it, or if there's any surgical technique that can be done that will allow you to excise the subpulmonary stenosis. On all of the pathological examples that I showed you today, I believe the surgeon can handle that and still do an arterial switch.
Sasha, any comments on that?
No,
From
I
your
think
perspective?
I really thank Norman Silverman, because today I think he did something that was not possible to attend in whatever meeting or other session. Because what are going to happen now that we have the addition of clinical experience, clinical imaging, advanced imaging, CT scan, MRI, reconstruction, printing. So what we are able to make, only the people like Norman or Bob can make a message so big and so clear that all the surgeons, I'm sure, will have a big opportunity to learn and to come in the theater in a very safe and very quiet way. This is what I feel today. Thanks.
Thank you, Norman. Thank you very much. And thanks for letting Congenital Heart Academy be part of the legacy that you have to the younger generations. Thank you very much.
Yeah. There are still some questions on here, Grace, that I haven't had a chance to answer. Will I be able to answer them by text, or how do I do that?
If you want, you can taste.
Yeah,
okay.
we can do that. Okay,
well,
guys.
I think that when you get into, there's a question here about big VSD. I think usually you can close VSDs. It doesn't matter how big, but you know, just make sure you're not dealing with a single ventricle, functionally single ventricle. All right, I think that sort of answers the questions. I want to thank everybody for listening to me. I see that we've managed to maintain most of the audience, and I look forward to the congenitally corrected transposition next month.
Nice. Next month. Please, if you like this one, please tell your team and join us on the next one. We are very happy to have